Welcome to the next episode of Endoscopy Essentials, and I'm more than happy to have the World Championship of ESD, Naohisa Yahagi. Welcome back.
Thank you very much for your kind invitation.
So we decided to do gastric ESD and start with the simple things and then expand during further episodes. Mm-hmm. So please enlighten us what you do, and if it's okay, I interrupt you with questions.
Yeah, okay.
Okay.
So today I'd like to talk about basic technique of gastric ESD, especially for the simple case. This is such a case. This is a tiny 0-2C lesion located at the gastric antrum, which size is around 2 centimeters. So it is necessary to check the target lesion very carefully regarding the extent of the target lesion and also invasion depths by using NBI magnification, sometimes chromoendoscopy, and also EUS. And this is a very flat lesion, and there is small depressed area which suggests a cancerous component. Therefore, I just sprayed indigo carmine and check the border of the target lesion and carefully place the marking dot around the lesion.
I have some questions when we look at that. If you have the impression endoscopically that this is resectable, would you still do endoscopic ultrasound?
Oh, no, it's not necessary. Only the case we suspect a deep submucosal invasion. In order to confirm the real depth of invasion, we sometimes use EUS. But majority of the flat lesion, we don't have to do EUS.
And if they are sort of contradictory on endoscopy, you think, maybe I can do this, and EUS sometimes is also difficult?
Yeah, sure, that's right.
You then just forget EUS and give it a try?
Yes, because endoscopic resection is not only for the treatment, but also as a complete diagnosis of making unblocked resection, and we can get the final histology before sending our patient to surgery.
So there's nothing wrong in trying ESD?
Yes, as far as it is safe.
Because I remember many cases where US said, it might be T2 and I don't know, and inflammation and da-da-da. So you get rather insecure. And but that was a very diplomatic statement. My second question is about markings. So you cut at the markings?
No.
Or around the markings?
Yes,
so the markings should be in the specimen?
Oh, no. We usually place the marking dot at least 2-3 millimeters away from the actual border line. And then we cut around the marking dot again at least 2-3 millimeters away, sometimes 5 millimeters away from the marking dot. Because sometimes tumor itself extending below the healthy mucosa, especially for poorly differentiated adenocarcinoma. That's why we usually try to have at least 5 millimeter safety margin from the border of the target lesion.
But that means a good ESD, you should see the markings in the specimen.
Yes, sure.
Yeah, okay. Because here it seems a little bit narrow sometimes, huh?
Yeah, but still there is 2 millimeter away from the marking actual border of the target lesion. And then I usually cut.
And you stay a few centimeters away from them?
Yeah, a few millimeters away from the marking.
So you always see them on the side when you cut?
Yes, sure.
Yeah. Okay,
sure.
Good.
That's very important.
Let's go on.
Yes. Now I would like to show you actual video clip of my treatment. This is the white light image. As you can see now, there is a shallow depression, pitch color a little bit reddish. Then spray the indigo carmine to enhance the surface structure. We can exactly see the irregularity of the mucosal surface. Then place the marking dot with the closed tip of dual knife. It's quite easy to make.
Which current?
I usually use soft quark. Not to injure the muscle layer itself. Then inject solution to the submucosal layer. I prefer to use a glycerol solution, which is a mixture solution of 10% glycerin, 5% fructose, and also 0.9% sodium chloride. It stays a little bit longer. And this is 2mm sized dual knife J. And I usually start the mucosal incision at the anal side because I would like to make sure the end point of the submucosal dissection. And I usually don't make a circumferential mucosal incision at the beginning because if I make a circumferential mucosal incision at the beginning, additional solution sometimes goes away from the incised area. That's why I usually make a partial mucosal incision, then quickly trace the inner edge of the incised area to separate the target lesion from the surrounding tissue. Now I completed the half circumferential mucosal incision at the anal side. Because I'm planning to make a submucosal dissection from the oral side in a straight position, therefore it's quite important to make an initial mucosal incision at the anal side as an endpoint of the submucosal dissection. Now I'm tracing the inner edge of the incised area. We don't have to go deeper part of the submucosal layer at the beginning. At least I trace the inner edge a few times, 2-3 times usually good enough. This is the first time dissection, and this is the second time dissection. It's nicely separated. This is third time dissection.
And you have enough fluid?
Yes. Then I usually give additional submucosal fluid cushion at the oral side, then restart the mucosal incision for the rest of the surrounding mucosa. Now we can see the marking dot nicely. I'm keeping a few millimeters away from the marking dot to keep the enough safe margin. Then again, trace the inner edge of the incised area. Sometimes beginners misunderstand that they should go deeper part of the submucosal layer. It's really a big mistake because we have to be careful not to touch the muscle layer itself. That's why basically I trace just the inner edge of the incised area at the beginning. Then after creating enough space, then we can easily open the submucosal space by utilizing the upper limb of the transparent food. Now you can see the beautiful submucosal layer colored by indigo carmine. Then I usually dissect 1/3 from the muscle layer within the submucosal layer, which means a little bit deeper part of the submucosal layer. Now I already dissected most of the submucosal layer, and the final stage becomes quite easy because I already separated the anal side at the beginning of my procedure. Otherwise, it becomes quite fluffy, and the final step usually becomes very difficult. Now you can see the beautiful resection bed. There is no muscle injury at all, and as you can see now, we can see the marking dot clearly on the specimen. This is the basic technique of gastric ESD.
Phew, very quick.
Yeah.
Almost as quick as snare resection.
Yes, sure. For this kind of lesion, I can remove it probably within 5 minutes.
Okay. But there are many questions.
Yes.
So I think one very important principle, you were mentioning that the distal side, as you call it, the anal side, if you cut around and leave it like that, just with a superficial cutting, you said you have problems at the end.
Yes, that's right.
So you have to take more of it, that the specimen sort of shrinks. So when you reach it from the other side, right, it's an easy job.
Yeah, sure. But at the end of submucosal dissection, sometimes the remaining tissue becomes really fluffy, difficult to catch the edge of the remaining tissue. That's why I prefer to make a deep submucosal dissection even at the anal side. And if the mucosal incision is really shallow, sometimes we make a submucosal tunnel.
Tunnel yourself.
Yes, behind the incision line. That's the big problem.
So I think most people, when they start, they find the circumcision most difficult because they don't know how far to go. But the message is clearly, please invest time. So be thorough and make it a bigger incision or make it a larger incision because at the end you will be rewarded.
Yeah, yes, sure. That's
the time you're investing initially,
yeah.
you don't need at the end.
Yes.
And you don't get confused and
And there is another important technical tips. At the beginning of the mucosal incision, we don't have to make a deep mucosal incision because there is a thick blood vessel within the submucosal layer. Therefore, I usually try to make a shallow mucosal incision, cutting just until muscularis mucosa to expose the submucosal the tissue. Then I can switch to the coagulation current for the initial submucosal dissection to avoid the bleeding situation. That's a really important technical tip.
Speaking about current.
Yeah, sure.
So the initial incision is how?
I prefer to use dry cut mode.
Dry cut mode.
But in some cases, I still use end cut eye, which can cut much quickly.
And how do you choose?
In case of having some fibrosis, I prefer to use end cut. But if there is no fibrosis, I prefer to use dry cut mode because I can control everything by myself. There is no interval, there is no duration, but by stepping foot pedal intermittently by myself, I can control everything. That's why I prefer to use dry cut
So
mode.
yellow pedal,
Yes.
dry cut,
Yeah.
superficial.
Yes.
Not too deep because then you hit the vessels.
That's right.
Yeah,
That's
okay.
right.
Very, very important. Good. And then you have your submucosa exposed and then you take the blue pedal with what?
Yes, I previously used Swift coag because Swift coag is powerful enough to coagulate blood vessel, but at the same time, it can cut submucosal tissue very nicely. But I completely switched to precise sect because Bio 3 has a new mode which is precise sect. It cuts much better and we can reduce bleeding during the procedure.
Because what we saw, there were vessels, but you didn't care.
Yes, because Swift coag and precise sect is usually very powerful, especially for the tiny blood vessel. Just go slowly to cut the blood vessel, then we can conduct bloodless submucosal dissection. But of course, if there is really thick blood vessel, I usually expose the surrounding tissue, then apply the very low setting of forced coag using open tip of dual knife. Then we can seal the blood vessel without having any bleeding. Okay?
But these vessels were not big enough.
That's right. That's why I just use the precise sect to cut through.
Precise, you see them, you slow down a little bit.
That's right.
You burn maybe a few milliseconds longer and then you go on.
That's right.
Okay.
Yeah.
And the other technique is also interesting. You were showing at EndoClub, I think, a few years ago. So you then if it's a bigger vessel, whatever bigger is, but that's experience, right? You dissect the vessel around.
Yeah.
And then you take the knife out.
Yes.
And have a low
voltage, low setting of forced coag.
force coag,
Yes,
0.3 or
0.3. 0.3.
So you burn the vessel then.
Yes.
It gets whitish. And,
Yes, that's right.
Good. Okay, now we have freed the distal margin. And you said you do the same on the other side?
Yeah.
You stay superficial?
Yeah. At the beginning.
Yeah, same principle, I guess, but then you go deeper.
Yes, after creating submucosal pocket, it becomes possible to go into the submucosal layer utilizing the limb of the transparent food. Then we can get the overview of the entire submucosal layer. Then I usually focus on 1/3 from the muscle layer, a little bit deeper part of the submucosal layer. Then keep the same level until the end of the procedure.
What about the angle of the knife to the tissue? Should it be more oblique?
Should be more tangential.
Yeah.
But in case of having a target lesion relatively perpendicular, I usually inject a lot of solution to have enough submucosal space and trace the inner edge again and again, not touching to the muscle layer. So it's technically really challenging, but still it's possible.
And slower.
Yes.
So not too hectic, as usual.
Of course not.
Because some early champions want to be quick, and I do this it's not necessary to do this in 5 minutes from the beginning, right?
Yes, that's right.
If it takes an hour, it takes an hour, but you learn a lot.
Yes. And also, if we go slowly, final results becomes really nice. And actually, as we can avoid the bleeding situation, then we can finish our procedure relatively fast. It's not bad.
Okay, and the cap is very important?
Yeah, sure.
So which caps do you use?
For the standard gastric ESD procedure utilizing gravity effect, I usually prefer to have Olympus straight cap. But in case of doing a little bit complicated procedure using the water pressure method, I usually use a Fuji SD foot, which has tapered tip.
Tapered tip.
Yeah.
Especially if the angle is not so good, then you have to dig under.
Yeah.
The solution you mentioned, a more viscous solution, is better?
For the beginners, the viscous solution certainly helps them because they can keep the nice submucosal fluid cushion. But for me, it's not so important because I can quickly open the submucosal space. And once we go into the submucosal space utilizing transparent food, we can visualize all the submucosal layer.
And now you have all these injection knives.
Yes.
So you can inject all the time or as often as you want?
Yeah, I just use a normal saline with blue color for the knife injection. That's usually good. Yeah.
And I saw, at least with that small lesion, you do one injection at the beginning?
Yeah, yes.
If it's bigger, you start with half or?
I usually focus on the area which I'm planning to make an initial mucosal incision, and then I just injected that's on that side.
And if you expect, because it's small and it's quick, you can inject everything?
Yes, that's right.
Okay, injection through the tumor? Is it
no,
forbidden?
never. Because there will be some risk of cancer cells seeding to the deeper part of the submucosal.
So always stay at the margin?
Yes.
I mean, it doesn't seem to be necessary, but what's your opinion with regards to traction devices?
For the difficult area, I also use traction device, such as a big lesion located at the greater curvature of the stomach. Because it's a kind of gravity side, we cannot open the submucosal space. Then simple traction, such as clip and line traction, makes huge difference. We can easily open the submucosal space.
So every time it's difficult and you don't have easy access, you can't dig under easily, then you think of traction.
Yeah.
And what kind of traction, like the French are doing? Or sometimes also pulling with a thread?
The traction system, which developed by French group, was probably only for colonic lesion. For the gastric lesion, I prefer to use clip and line traction, which is very simple and cheap. It's quite effective.
Okay, but you have to have a plan where to and at which end and
Yeah, that's right. That's why I made conclusions, right? That it is really necessary to check the target lesion beforehand and place the marking dot precisely, then make a treatment strategy considering maneuverability of the endoscope and also direction of the gravity. So direction of gravity is very important. If we can utilize it, we can easily open the submucosal space. And if we cannot utilize the gravity effect, we should think about the traction device.
Okay. So think twice before you start.
Yeah, sure.
Or maybe even more than twice. Well, fantastic. That was like a super trailer to the more difficult sessions we will record in the future. Thank you very, very much.
Oh, thank you very much. It's my great honor all the time.
Thank you.
Thank you.